Wij gaan over naar onze eerste spreker van vandaag. En daarvoor gaan we naar het buitenland. En therefore I'll switch to English. Our next speaker is from Germany. And we can learn from our neighboring countries a lot. And also in healthcare. Thomas Hagemeijer will represent you on what they call Diga und Dipa. That's interesting. Now try to switch to German, which is not a very good language for me. He'll talk about providing completely digital therapies on recipe as well as not on recipe, and what he encounters in Germany. He's the health lead at TLGG Consulting in Berlin, and give him a warm applause.
Thanks a lot. That's the topic for today. So, not Diga, but Diga actually. Diga and Dipa. Just a few words about myself first. I am actually not German, I'm French, but I do live in Berlin. My passion is about digital health, and my mission, my why, if you want, is to make the health system shift from sick care to well care, and ultimately to One Health, but that's not the topic for today, it's a broader topic. Just one step back before why are we here, and that's the story we like to tell. The system is showing its limits, and when I say the system, I mean the healthcare system. And I don't mean here you only have German examples, or mostly, but I think in all Western Europe you have a similar dynamic. The three main stakeholders, so payers, providers, and patients, are experiencing major challenges. If you look at the payer first, the costs are exploding. Here you have some example on nursing, but in general, the whole healthcare costs. So we have the numbers. In Germany, they are growing at 4% every year in the last 10 years. And we expect a GDP growth in the coming years of 1 to 1.5%. So on one side, 1 to 1.5% GDP growth. On the other side, 4% healthcare cost growth. That means at some point, we won't be able to afford our universal healthcare system anymore. We'll always decrease the services. That's a bit the problem we're facing. On the provider side, there is a big issue, like right now, about the lack of skilled labor, at least in Germany. You will have 500,000 nurses missing by 2030. That's on the nursing side. You also have a bigger challenge, or a big challenge, on the physician side. The numbers as well, so there was a survey from Medscape before the pandemic, 2019. In Germany, 44% of the physicians are suffering from burnout symptoms or depression symptoms. In France, it's 48%. I don't have the numbers for the Netherlands, but you have a similar dynamic as well. So the providers, the physicians, nurses are also at their limits. On the patient side, you have a poor experience, maybe but basically there was a survey also last year in Germany from YouGov that almost half of respondents said that the nursing has a poor reputation, nurse experience is poor. And obviously I'm French, so I pull this example of Orpea. I don't know if you have heard of it. That was a big scandal that's happening in the last month. Also showing a bit that the patient experience is not the best. Diga, Dipa, what's the difference? So first, before I come to what's a Diga, what's a Dipa, all the eyes are on Germany right now because of Diga and Dipa. So that's the first country, Germany under Jens Spahn, that decided to put a policy in place, so Diga and Dipa, for the reimbursement of digital solutions. So that's basically Diga and Dipa. The reimbursement of digital solution at scale, at a national level. That's why all the eyes right now are on Germany and want to understand what is it, does it work? And in a way, Germany, even if Germany is kind of a laggard in healthcare and digitalization, they position themselves as a leader in digital policy. So leader in digital policy, but still a laggard in digital adoption. But one trigger the others. So here we listed basically the key differences between Diga and Dipa. So essentially, Diga, so the German translation, I think, is digitale Gesundheitsanwendung, which may be like similar in Dutch. It's basically, the English translation will be apps on prescription or reimbursed digital therapeutics. DIPA is reimbursed care apps. So they are both digital solutions, but they have both a very different purpose. The Diga is really there, and I heard, to replace potentially a pill-based therapy, potentially replace it for some indication, or for some others it will go along the medical pill-based therapy to achieve better results. It's not necessarily replacing. The DIPA is very different. The DIPA is really there to support the everyday care. It's not there for the therapy. It's more there to bring efficiency, better communication, better planning. That's basically the purpose of DIPA. Just when did it start? That's important as well. Diga started in end of 2020. That means we have a bit more than 1 year of data, while DIPA is actually starting now. So we don't have much. The policy is there, has been voted, and is starting to be implemented now, but we don't have a lot of data there. So as I said, both are reimbursed at scale, but they're not reimbursed by the same payer. The Diga is reimbursed by the statutory payer. So I know that in Netherlands you have a different system, but the statutory payers, the Krankenkassen, they are the sick funds. They cover 90% roughly of the population. Basically, if you earn less than 60,000, you're automatically insured by the statutory payers. That means they're reimbursing these digital solutions, digital apps, or digital therapies at scale. The DIPA are reimbursed by the social care fund. The distribution model is also different, as we showed there. One key difference is obviously Digas are a prescription, like an app on prescription, so they are prescribed by the doctor, while the DIPA will be basically requested directly by the patient or carer. One key difference as well is the Diga is a medical product. You really have a certification process in place with randomized clinical trials that show the clinical value of a Diga. It's quite of I mean, the process is still like always being iterated, but that means you can't become a Diga overnight. There is a 3 months to 1 year process to become a Diga. A DIPA is not a medical product. And then the last point, the price ceiling. There is no price ceiling for Diga. Right now, the price is around 500 euros for 3 months therapy. Payer thinks it's a bit too high. That's why there are a lot of discussion right now, value versus price, and it's still ongoing. The DIPA, there is a price ceiling, it's capped at 50 euros per month. So there is less discussion. Anyway, it hasn't really started yet. So just a few more data on the Diga, because we have some data. So far you have a bit more than 30 digital apps that have been certified as a Diga. They went through the process, they have proved their clinical value, and they are now certified. So what you can notice, obviously, a lot in psychiatry and a lot in orthopedics. They're the two like where you have the most Digas. That also makes sense. That's a great use case. But they are not only psychiatry and orthopedics. And if you see, you're covering a wide range of indication. It's just starting again, so you can expect even more indications in the future. And second point for the audience, most of these indications are relevant for elderly care. On the DIPA side, again, we don't have much data. There are no DIPAs certified yet, but we expect these categories. So as I said, it's not a therapy, the DIPA. The DIPA is really about assisting everyday care, supporting everyday care. So just here some example of categories. You will have assisted living, communication between the nurse and the patient, planning and organization, physical care and cognitive care. Physical care and cognitive care, they're like the closest to the Diga, but they won't be medical products. So that's the main difference. Just some concrete example. What is a Diga? And here we just pick the 3 most prescribed Digas so that you know roughly how it will work. So Vivira on the left for back, knee, and hip pain. So back pain in Germany is the #1 reason people visit a doctor. And basically you will have the patient giving his data, always feedback to the app, and then you have a medical algorithm providing a personalized training. And I think this logic of data algorithm, personalized training is at the core of Diga, basically. And then the complexity and intensity will gradually increase, but obviously tailored to the needs of the patient. Then the second one, Somnio, at least similar dynamic for a different use case. You have all the data from the patient that are gathered. You have an algorithm and a behavioral therapy tailored to the patient and a regular evaluation. And the last one, Calmeda, it's interesting because it's for tinnitus, so a very specific use case. And you have also similar dynamic. You describe your symptoms, you have a personalized algorithm, and then the support is provided post-therapy as well. On the Diga, again, no DPAs are certified yet. However, that's the soon-to-be or the expected DPAs. One is Lindera, which is actually quite well known. They have a partnership already with Corian, which is a French care organization. And what they do is fall prevention using using the risk factors, and they basically reduce the risk of falling. The second one, EMA, is interesting because, as you see, this one is actually not an app. It's a sensor, smart assisted living. And I think, you have seen a lot of these, I assume, but the idea is so the whole point of DIPA is not to have, you have many of these solutions. And I think the whole point of Diga and DIPA is to put a threshold, if you want. You have hundreds of thousands of apps and hundreds of thousands of solutions. And the whole point of this Diga and DIPA is the payers and policymakers trying to understand, out of these hundreds of thousands of solutions, which one are really relevant, which one are really bringing value, and putting a framework in place in order to take the 0.1%, I will say, and bring that to patients. That's a bit the whole point of this policy as well. And then you have NUI, which is exactly like a planner for the organization of everyday care. Diga adoption and challenges so far, and what does it mean for DIPA? So that's the numbers so far of Digas. So if you look at the left, we had 140,000 prescription of Digas so far. So far from December 2020 to December 2021. So for 1 year, that's 1 year of data. So if you look at the curve, it looks actually good. It looks exponential. So if it continues like this, it will, it's actually great for Digas. But still 140,000 is still a drop in the ocean because there are 400 million prescriptions per year in Germany. So it's still not relevant at the national level. But if it continues like that, it will absolutely have an impact. On the right, in the middle, we listed the key challenges for Diga adoption. The first one is awareness. So as I said, a Diga is an app on prescription. It has to be prescribed by a doctor. And the problem is that the doctors are not aware about it, don't really understand it deeply. So as of today, 1 year after launch, there are only 4% of HCPs, so healthcare professionals, that have prescribed the Diga. That's not a lot. We could have expected more. For the DIPA, you'll have a similar challenge. Obviously not the doctor, because the doctor is not involved in the DIPA, but the awareness and the understanding for the nurses and for the patient will be a key challenge. So education and communication. The second point, patient demand. Only 15% of Digas were prescribed have been triggered by the patient. We were expecting more. We were expecting at least 50%. The assumption is that a lot of patients are more digital native potentially than some physicians, and you will have expected a higher number. So 15% is kind of disappointing. Maybe it's just because the right use cases are not there yet. Maybe it will improve in the future. And that means for DIPA, because DIPA, the patient, will be one of the key adoption driver. With the nurses, yes, there will be a similar challenge. And how to tell the story about DIPA and Diga to patients and nurses will be also a key point to address. The third point is the data security. In the framework right now, in order to make things faster, maybe, the Digas are responsible themselves for the data security, which is not maybe the best. It might change in the future, but the Digas are startups, so there is maybe sometimes a tendency to invest in this. It might be fixed in the future, but obviously if there is a data breach, that's a big lack of trust. Trust is broken basically, and you want to avoid that. the DIPA will have a similar challenge, obviously. The fourth point is value versus price. There is clinical evidence for Digas, so they have to go through randomized clinical trials, but still the payers, the policymakers and the startups that are doing Digas are still like, there are a lot of debates going on about what is the right price point. As I said, right now for 3 months you will expect like between 300 and 500 euros. Yeah, I mean, that's the discussion that's going on. It's still basically being iterated by the payer and the policymakers. For the DIPA, you will have less of a problem. There is a cap, 50 euros per month. So the discussion, there might be some discussion, but much less. And the last point, which is actually maybe one of the biggest one, the HCP compensation. You have to imagine that the GP didn't ask for the Diga, they don't have time, and now they have to understand something else on top of, and as I said, 44% Germany already like burnout symptoms and depression symptoms. And the point is, it takes a lot of time to understand it, to prescribe it, to follow up with the patient. And the compensation model, I mean, at the beginning, I think maybe it changed now, but they were thinking about 2 euros per prescription and then 7 euros for follow-up, which is not aligned with the time invested by the physician. That's why there is a big issue. The second issue is that the Diga and DIPA, I mean DIPA not really, because they will be more on the care and not really in the doctor side. But the key problem is that the Diga don't integrate very well in the clinical workflow. So you will have the patient coming up with his Diga and showing the data to the doctor. The doctor has his practice software from the 90s, and obviously they don't integrate, and the doctor doesn't want to look on the screen. So in the end, it triggers a lot of inefficiencies because you have an old, like outdated system and a Diga, and they don't match basically. And that's one of the biggest issues. Now talking really about the impacts, how do Digas and DIPAs address nursing costs? That's only one aspect of it. Obviously there is other, but I wanted to be very clear on the Opla. This one disappeared, maybe it's after. Yeah, it's there. So looking at the nursing costs, so here on the left side you have the German nursing cost, so Pflegekosten. From 2010 to 2020, the first thing you notice is that they're increasing. They're increasing a lot. In 2010, they were 25% of the total. In 2020, they were 31% of the total healthcare cost. And they're accelerating. 2018, the growth from 2018 per year to 2020 was 9.3%. And from 2010 to 2018, the annual growth rate was only 5.6%. So coming back to my first slide, I mean, the costs are obviously a big issue. And here, just on a high level, the point I want to make is that Diga and DIPA can help reduce, maybe it's a bit ambitious, but at least contain this cost. And you have these 5 categories. So this reporting is the reporting from the German public institution. You have care services, stationary, ambulatory, and households in yellow. And obviously, DIPAs in these care services for stationary will play less of a role. However, with DIPA, you could swap or switch some stationary costs towards ambulatory and private households enabled by DIPA. And then obviously for ambulatory and private household, you will have a higher impact. And then for all the therapeutic services, you will have also Digas having a high impact on ambulatory. And again, with the same idea, maybe you could swap some stationary cost towards ambulatory. The therapeutic services are mainly physiotherapeutic and psychotherapeutic services. And as we saw, physiotherapy and psychotherapy are 2 main indications addressed by Digas. So yeah, obviously this is very high level, and you will have to go much deeper into the business case, basically. How much can I reduce, how much can I contain with the Digas and DIPAs, but as a starting point, and how to frame, basically, the business case. And so my last one is there. So that's the conclusion. So moving forward, in order to really like leverage Digas and DIPAs, and for you basically, what will be the next steps? Maybe not directly for you, but at the political level, there needs to be a European Diga and DIPA reimbursement framework. The main reason is if you want to ensure quality, you need to have always more players coming in. You need to make the market interesting. So the more you can have Digas that can scale across all the European markets, the more players and bring higher quality and better impact. And also you want to have European players and not maybe US players in the European market. The economical, I just touch upon this one. There is the payers must develop the transformation case or the business case to understand really the potential. And I just show how to frame the problem on the previous slide. And the last one, very important as well, Diga and DIPA alone won't fix all the problems. They're just one building block. And I think the key thing is about this integrated, and we call it digital health platforms. In the end, you don't want to have 3 Digas and 3 DIPAs on your phone. You want to have one app that coordinates everything. That's what we call digital health platforms. So this kind of user journey integrated and the Digas and DIPAs that are actually maybe white label solution just plugging in. That's how it should go, and obviously integrated as well with the doctor's practice. So this is why right now you have 2 parallel worlds. You have the Diga, DIPA and digital health world and the legacy healthcare system, which is not, they cannot basically integrate these new innovations. So yeah, that's it from my side. I hope that was useful.
Thank you, Thomas. We learned some new abbreviations of Diga and DIPA. I think you shared an excellent way. I should move a little bit. Excellent way the leadership of Germany in policy setting, and of course the great ambition is to also have this as an adoption. I think if we look at the ambition that Annette shared before, to move to 30% digital, we need solutions like this. I'm looking at all of you. Maybe you have questions for Thomas. He's now in the Netherlands, so let's take advantage of that. And I'm looking for the box. There it is. Do you have a question?
I already have my question, so.
It's... throw it.
Just maybe before the question, maybe sorry to you. I mean, there was kind of a question in your comment. You see in Europe that a lot of following Germany. So France announced, Emmanuel Macron announced in November last year that will copy and paste the Diga system. In Belgium as well, you have actually a system in place which is quite advanced. In the UK, you have also a kind of a system. I mean, the UK is technically not Europe anymore, but basically you have like everyone following the German example.
Okay, good addition.
Yes. Yeah. Actually, I have 3 questions, but maybe we can talk later in the break. I'll mention the topics. The one is about the reimbursement. Is that per month or per solution, so to say, on the DIPA side? The other question is about, let me see, the certification. What kind of criteria do you have for certification of the DIPA? And the third question was about, you mentioned that it's important to have only one app that's integrating everything. Sounds easy. I think Maarten van Rixel also mentioned the integration is an important topic. So I wonder, did you already achieve that, or is that a kind of something that still has to happen? So I think if you maybe answer one, then the rest will come in the break.
I'll try to take them backwards. So on the digital health platform, actually I could share, we have a white paper on this that explains a bit this whole thing, but yeah, you will have to have, and I really bet on Doctolib actually, for example, as a potential digital health platform, because it's a great entry point with online booking. So you don't have Doctolib in the Netherlands, you might have Doc Planner, I don't know which one you use, but an online booking solution as a great entry point that integrates all the other solutions into one. Doctolib as well is partnering right now with the French government for the digital health record. So you will have a kind of, I mean, we don't know in which direction that will go, but you will have those players that have a very strong first use case. And the online booking seems to be very simple, but for me, it's the strongest use case because it's already a problem for the patient and for the physician, and most of the time the solution solve either or. So I really believe in Doctolib, not because I'm French, but because I think the use case is there. Or you might have some retailers coming into the game as well. In the US, you have Walmart, that is, and in primary care especially. In Germany, you have Otto, which is a big online retailer that just bought a telehealth player. So the retailers with their huge customer base and their kind of already very digital first approach. So you have Amazon obviously in the US. They also might be the one that are the front end and they integrate all the others. So that's this kind of two scenario, either digital health scale up like Doctolib or retailer like Otto. The first question was about, one was about the price and one was about the process, I guess. So the first one was about the Diga and DIPA price. I think it was a DIPA.
Well, the DIPA, especially the DIPA.
So the DIPA, again, I mean, I would have preferred to answer on the Diga side because it's clearer. On the DIPA side, the policy has just been voted and it will change. So right now, the logic is 50 euros per month, as much as you use it. But it's very unclear about how and what and everything, and no one has a sense about is it, I mean, just like very ballpark number. But there is a cap of 50 euros per month, as long as you use it. How will it really materialize? There's still a lot of unknown. On the Diga side, it's a reimbursement per therapy. Yeah. A therapy is on average 3 months and costs, as of today, between, like, say, 300 and 500 euros for these 3 months.
Yeah.
Okay, thank you.
Thank you, Thomas. And there was a question behind you, so if you can throw it to the back of the room. Thank you.
Yes. I have a question. Who decides which apps are integrated in DIPA? And what do you do when, for instance, for fall prevention, 20 different apps want to be integrated? Is there always one chosen per subject, or you know?
So basically, I mean, on the DIPA process is still ongoing. The Diga process is BFARM. So you have basically entity body, public entity body, like from the policymaker running all this process. And for DIPA, that will be the same. It will be exactly, BFARM might be another one. But you have this, like, from a policymaker. And I think in the BFARM, you might have some payers inside. So kind of a public mix of policymakers and payers defining the process and running the process. In terms of the 20, so I think in the end, it's not, it's a bit of this idea of a threshold, basically, you know, like you have 20 prevention, the 20 might make it, or 0 might make it. You know, there is just like a threshold, so like a process to go through. If you go through, good for you. If you don't, then you don't. And in the end, if you have 20, I mean, as a payer, I think it's a bit different because you have a different system in the Netherlands. But basically, then the one that will decide are the patients. So they will have 20 prevention apps and the one with the better UX, basically, because I think the process doesn't really test the UX, the user experience. It tests more the clinical value or the medical side of the Diga and DIPA, and then the patients will decide which one is the best for them.
Well, thank you. It's clear. Yeah.
Well, thank you, Thomas. You will be around for the rest of the day?
I'm staying there tonight in this hotel, so I will be around for sure.
Well, thank you, Thomas. Give him a warm applause.